So with that, let us reawaken ourselves as we begin the post-lunch scientific session. For this session, may I first invite Dr. Mrinalini Kothru to kindly grace the chair. Dr. Mrinalini is Director Professor at the Department of Pathology, University College of Medical Sciences, Delhi. With over 23 years of experience, she has authored more than 90 publications in index journals along with several chapters and abstracts. Thank you, ma'am. And I now request Dr. Sufyan Zahir to kindly co-chair the session. Sir is the Director Professor of Pathology at VMNC and Safdarjung Hospital with over 100 PubMed index journals, publications and editorial roles in leading journals. His work in tumor microenvironment and histopathology is widely recognized. We are honored to have both of you preside over this session. I now request the chairpersons to kindly introduce the speaker for this session, Dr. Pranta Chakrabarti, who will be speaking about the role of AI in modern hematopathology.
Wanajua nataka driki hizo vitu.
From glass slides to algorithms, I think, right? Anyway, it's all the same.
Presentation is from glass slides to guided decision, artificial intelligence in modern hematopathology. Sir.
Yeah. So welcome back. I know it would be difficult to remain awake, and intentionally I do not include polls in the presentation like Dr. Dey, but you have to prove that you are not asleep. So both of them, Nishant, also known as Rajat, and Dr. Dey, they have made my task simpler. So, no, Rajat. No, that only shows you that the model is as good as you train it, right? If you train it, it remembers that name only. So, Dr. Nishant gave you a very good perspective in the morning, and I would like to emphasize that anything artificial is a copy, right? And one thing you have to remember is we only understand 10% of how the human brain works. So even if we are a very good copy maker, we'll be able to copy 10% of it. So we are trying to reproduce the human brain's function, and we have given this capacity to machines so that they can memorize and vomit out what we have done during our medical career. But it can also think and create, speak, act, whatever you want, and whether it can judge and make decisions, that is a $1 million question, or you can call a crore rupee question. And this was shared by Professor Dey, that you have that whole universe, within it was machine learning, and then there was deep learning, but it became popular when you had those large language models within generative AI and the transformers. So incidentally, there was one article from the Google team which said attention is what it needs. So if you get time, I'll tell you, but let me tell you, AI is nothing new. Okay, so unlike iPhone iterations and other things which come up every year of cell phones, there are actually 3 generations. Generation 1 started when most of us were not born. Okay, those were symbolic AI and probabilistic models. It was directly, we were encoding the rules. If this happens, you do this. And strangely, in clinical practice, most of our clinical decision support systems still run on that. But at that level, IBM's Deep Blue beat Kasparov. Okay, so don't underestimate even human-driven encoding. And in healthcare, as I told you, clinical decision support. But the problem we have discussed that our bias, our errors would be amplified in that. For almost 50 to 60 years, we were trying to develop it. Then came deep learning, which can now classify or predict. So it was not about, is this a cat or a dog, But how many dogs can be found in front of your academic block, say at 1 p.m.? Because that data also is there, and most of the tools we use in our phones are this version 2.0, like prediction of the next word, correction, you're using Grammarly or Quillbot, voice recognition, voice to text, Scribe. In healthcare, if you look at those reels which come, Google is doing this and all, diabetic retinopathy screening, skin condition classification, prediction based on your electronic health record or your journey, these are also from version 2.0. There the problem was that there were out of distribution problems because real-time data and what it was trained on was different. But there was one thing which we learned from that was catastrophic forgetting. Now humans also have this, if I keep on talking, you will forget most of what I said. Here what was happening is, as you reach the end of that statement or prompt or whatever you call it, it would forget what was said in the beginning. That was 2.0. And then just near to COVID, you had this foundation models. So these are generative AI, generating new, and it can tell you the difference between a cat and a dog, but not how we know it. So basically these generative models are statistics on steroids. So it knows that when you mention cat and when you mention dog, most of the time humans say dog chases a cat or cat is afraid of a dog, and to make things very simple, there are tokens. By that token and by that weightage, it deduces how a cat is different from a dog. And so the writing assistants you have, software coding assistants, chatbots, agents, they are all part of this. In healthcare, you have MedPalm, MedPalm 2, now you have MedGemma, MedGPT and all those. But here we got something which we knew that we were overfitting because it was learning on its own. But what you got was that this model can be confidently wrong, right? And that is what we call hallucination. So you tell it to write a review article on anything, it will generate 50 references, none of them exist, right? So you have seen an alcoholic, right? We were taught in psychiatry also how an alcoholic hallucinates. And the most important term here is it is confident, but it is wrong, right? I am not going into what people think of their spouses, but it's almost the same, right? So machine learning and deep learning are basically, deep learning is a subset of it. It does in a different manner, and you have all these KNNs, convoluted neural networks. I will not go into details of all that, because if you want, you can read about them just to get an idea. But first myth is that you have to know good mathematics and coding to use AI is not correct. Okay, I'll come to it later. So I call it healing with algorithms. 3 areas where we are somewhat there. Radiology, obviously, I will not be discussing today, but I will not only be discussing pathology, taking some cues from Dr. Dey, but I will also go into what is happening in the genomic field. Now, why? Why we need AI? This was also discussed, that there is a data tsunami, right? And 40 billion GB of genomic data are being generated per year. I am not talking of the articles which are being done, because in India people publish articles to get promotions, right? So, but that is also, you are supposed to read it and then say whether it's a genuine paper or a tissue paper. And the problem starts from there, because the delay in having that cognitive assessment and summarization is very difficult. 99.9% of the genetic variants, if you give it even for next generation sequencing or whole exome sequencing or whole genome sequencing, it will come as variant of uncertain significance. Now what do you do with that? The patient is confused, you are also confused. Now specifically in hematology, you have to understand that we hematologists, like we are supposed to be the best pathologists amongst clinicians, and the best clinician amongst pathologists. So we have that kind of a dual role. It is one of the most data intensive medical specialties. So that's why you have a large amount of data, be it from the peripheral blood smear, from the automated cell counter, from flow cytometry, genomic studies, multi-omic analysis, and he mentioned about proteomics, transcriptomics. The latest omics is really big data. Does anyone know what is that omic? Which only AI can handle. And that is what we are calling as exposomics. Right from the womb to the tomb, whatever we are exposed to, internal environment, external environment. And that determines not only our diseases, that determines our health. Okay? So this wealth of data presents both opportunities and challenges. Challenges we all know. I will show you some opportunities. If we call ourselves, the pathologists, human diagnosticians, we have some inherent limitation. You have cognitive fatigue during long microscopy sessions. If you look at the consensus papers, most of the time you will see there is no consensus. Because they cannot agree, dysplasia. What is the degree of dysplasia? What is there? So there is a lot of subjective interpretation. And then you have time constraints. If you say, okay, I have your data, I'll give you a report after 2 months. Well, some places actually give a fibrinogen level also after 7 days. But if you say like this, by that time either the patient is cured or the patient has died. So you can't afford that. So these challenges become particularly acute when you deal with rare cell populations. And nowadays, we are doing single gene sequencing, single cell sequencing, looking at the clones or subtle morphological changes. So here it becomes more important because AI excels in pattern recognition. By this time, all of you have understood that. And high dimensional processing, right? Actually, when there is more data, the chance of overfitting is bit less. That's why data is so important. And then it can do what we call forecasting or predictive analytics based on advanced algorithms like prognostic biomarkers or all those. And that is why all my previous speakers have also told you that it augments rather than replaces clinician, because it's a powerful diagnostic adjunct enhancing our human expertise, okay, while preventing the irreplaceable clinical judgment which actually defines quality care. So evolution has been from seeing, either using a microscope, some of us have been using digital images also, using a trinocular, but now it is not about seeing, not about subjective interpretation, not about siloed data, reactive efforts like detecting disease. It is more about integrated, multimodal, proactive, and we tell that forcing disease. Because I have told you about that 40 GB story. So the current state is, you first look at the clinical record. First you take a history, which most of us forget that is also a diagnostic tool. Then you look at the past records, and then you look at the laboratory reports and you want to do it. So just like in the computing world, in the medical world also we are now going to parallel computing, right? So you get all those things, maybe you have a dashboard kind of thing and you do it. So Dr. Nishant and Dr. Dey told you about some of the toolbox. Without going deep into them, let me tell you, one are the vision models, where they are heavily used in radiology and pathology. We call them convoluted neural networks or vision networks. And then you have the transformers. How many of you are using ChatGPT daily? Raise your hands. See? Very frequent. So it's almost 40%. So it can interpret sequences also as text. So report generation in genomics, and then you have multimodal models, which was right? And then you have what we call as generative AI. So transformers are one of the ways of being generative AI. You can have even novel protein design diffusion models and other things. Now, this is so-called AI ML enabled FDA cleared devices which I downloaded in December 2025. So who is the big dada? These are FDA approved devices, right? It's radiology, right? So others appear minuscule. So you'll be wondering, I told that hematology is a very good fertile ground. Where is it? Let me remove the big data. Then you see it's cardiovascular, neurology, anesthesiology and hematology. Actually approved models are less than 20. Right? This is from the FDA website. Now, let me go back. As I talked about the generations of AI in healthcare, which was from Journal of American Medical Association, you have to understand by 1980s, we already had image processing software, like automated blood cell morphology. Then, in the 90s to 2000, we had rule-based expert system, which was a part of that iteration, which I talked of, rule-based, decision making. Then ML algorithms came in, SVMs, random forest, gradient boosting, and then came the deep learning revolution. This is how it has gone in our field, that is hematology. Today, we are trying to get a new molecular structure, synthesize synthetic training data, find druggable targets, and then design drugs for it. If you remember, doctor, they showed you this, right? This is an analog image on the left, and this is digital whole slide imaging with AI, which can actually tell you about the Ki67 count. It's about pattern recognition. I'm not going into how it does it at all. But computational histopathology in 2026 is actually the operating system for precision medicine. And why machines sometimes do better than us? Because it can see the unseen. It can predict molecular mutations directly from tissue morphology. Do you remember his question? That can you predict molecular without doing molecular tests? Right? It can be done. PathChat he talked about. Vicho, we all know who Vicho was, but there's a model after him also, vision language. So PathChat actually achieves around 89.5% diagnostic accuracy, but obviously in the real world, this is not enough. So the first step here is obviously digitizing the physical world. If you even go to some of the renowned hospitals in Delhi, you'll see that the doctor is writing a prescription and then someone scans it and keeps it. So what is that? It is sometimes not even human readable by the same human. The doctor cannot read his or her own handwriting. It is not machine readable. And so if it is not machine readable, it is not machine understandable. So unless you digitize, you will not be able to do whatever I am showing you here. So then comes obviously what resolution you will use, and the cost goes up if you do it. But again, Moore's law has been overtaken here also. If you look at the resolution of your phone camera today, that is amazing, and Hollywood films are being made using today's smartphones. So we are calling it H&E Unleashed. So traditional was you do a DNA sequencing, weeks, and then 20% of the information comes. Now looking at your H&E stain, there are certain things like, BLC, FGFR or CRC, which screens for colorectal. And I'll tell you, some of this are actually reimbursed by US insurance companies also. So we are trying to quantify the subjective. It's no longer about two pathologists fighting that yes, there is dysplasia and there is no dysplasia. So HER2 low agreement was boosted to 86.4%. Even ultra low agreement was close to 80%. And I think there's an ample scope. So this is Ventana, which Dr. Dev was talking about. Now you have the generative copilot. So getting data from Vicho, Gigapat, Conch, enable language interaction. Once it sees your slide, The pathologist can ask such questions, identify regions of tumor heterogeneity and suggest ancillary stains. It is possible to do it. But the most important thing which he told you, and you can never afford to forget about that, is multimodal fusion. That is the way forward. Most of the applications which now are applying for license are multimodal. So histology, clinical variables, genomics, and then you give a risk score. So this is prostatic cancer determination risk, which gives you a high risk score with 92% accuracy. I will not go into pharmacogenomics and big data interpretation, but what I would like to tell you is that you now become a liberated pathologist. Not liberated to do whatever you want and take more coffee, but it will help you when you are not feeling like doing this work. So, traditional workflow was 80% screening, 20% diagnosis. AI assisted workflow is, it does 90% of the complex diagnosis integration and 10% is there where it cannot also perform. So when you are the head of the department, obviously your residents will not show you all the slides. So think of AI also as one of your residents. So enterprise scale and commercial consolidation is going on, but if we talk of economics of AI pathology, those codes are American insurance codes, because even if you read Harrison's textbook of medicine, some of the criteria for dialysis was according to the insurance companies because they are very powerful there. But they have approved reimbursing when you try to look at microsatellite instability analysis, homologous recombination deficiency, emerging technology in certain other cancers. In India, do not think that these models will work. Let me be very clear, and I'll tell you, we all agreed on that because it has been developed at Stanford and Harvard, it will be doing very good work. That doesn't work at all. So you have to develop your own, and you can then decode complexity because it's a numbers game, right? HLA-DR, attention-based multi-instance learning model, which looks at it. So digital morphology has been there for more than 30 years. How many of you have heard of CellaVision? Raise your hands. Well, this is a Swedish company which actually sells its products along with the cell counters. So they were with Beckman Coulter, they are also with Sysmex. And what they were trying to do is exactly what we have discussed. And how are they improving it? So you have some YOLO version 10 models. You have taught them 12 different distinct white blood cells subtypes, and they are doing a reasonable job, obviously with pathologist in the loop. For bone marrow pathology, so in Medanta, one US model was being tried out. So it was giving correct diagnosis in almost 90%, and you have Inception V3 based deep learning architectures which has a Cohen's kappa coefficient. These are all statistical things, closer to 1 is good, that's all. So 0.83. Emerging vision languages such as CLIP, MetClip, they are the next frontier, and I was looking at how people are now doing the trials and applying to FDA. Most of them are using this vision language models only in bone marrow morphology or peripheral blood. Now flow cytometry, it's an ideal ground because it's all numbers. Even before these models came in, we used MATLAB to help interpret, because the problem here is when BD sells its flow cytometer, it will sell its own software. But you can develop open source software and then run it. And mind you, in 2023 to 2025, BD, being majorly a flow cytometry company, has acquired 22 startups working on AI. What does this tell you? So, Dr. Nishant was telling, when you read Economic Times, you get a perspective. The perspective is all the equipment manufacturers are going to embed this in their instruments, because they want to sell the instruments, but they want to make it smarter, right? So, unsupervised clone discovery, automated gating. Gating is a challenge. So, in a tier 2 or tier 3 city, you might not get someone who is so. For MRT, 1 log sensitivity can be increased using those tools. If you want to read it, I will give you certain articles which are published in medical journals, like automated deep learning based diagnosis using flow cytometry. This is almost more than 3 years old, right? 23, no, not 3, 2 years. And they have shown how, this is the area under receiver operating characteristic. This is what we use to understand how robust that model is. We obviously look at positive predictive value, negative predictive value. And I am not a hardcore hematopathologist, but the figure they have given, left done by a human, right done by the machine, I at least cannot see a difference, and I have given you the reference. This is how automated gating is being done. So you can have, you do not need a, now people are working on almost 30-40 color flow cytometers. Even if you have 3 to 4 colors, you just capture the data, your basic work, including MRD, can be solved by AI. Cytogenetics and karyotyping, this was always a problem. So, Professor Amre, who is in Tata Memorial, used to tell me, Prantar, to be a good cytogenetist, they need to invest 20 years. Now, the technicians or the pathologists do not have so much time, and in 20 years, the technology will again change. So, we are using certain models which provide automated recognition of critical cytogenetics, and then you have something called transformer models, which have been trained on more than 50,000 different structures. But then, why do you need a cytogenetist? Because there will be some which are being discovered for the first time. So, you have to have it as a tool and a human as the man behind the machine. Then it's liquid biopsy, right? There has been a lot of hype about it, but we are trying to do, at least using AI, enhance the signals, because they have very few cells like circulating tumor DNA. Multimodal fusion, again, you get a biochemical data, you can look at the thermodynamics, and then you use CatBoost integrative models which combine it with clinical parameters, RNA profiles, and then give you a better insight. So relapse prediction in certain solid tumors also, it has been brought forward by 4 to 8 weeks. That is what the publications say. But when I talk of multimodal, let me give you an example. This is a CT scan image which integrates your histopathology findings along with this CT scan. You can integrate your PET CT also. And then convolutional neural networks actually do a great work in telling you how heterogeneous the tumor is. And when you are trying to analyze it and then looking at some biomarkers, this kind of multimodal fusion is helping us. So there are already some models. I will not go into the details of the models. You can all look up. These are all in the public domain. But we are using something called graph neural networks and graph convolutional networks and then graph attention networks, which all are trying to help us. Because you can imagine the amount of data we are generating from a single cell. It is not possible for a human bioinformatician to interpret it. So AML is one of our most difficult diseases, right, in hemato-oncology. So here is this machine learning approach to integrate the big data, integrate the single cell data and try to understand which drugs will act in which people. So this is what we call as precision medicine. This is precision oncology, which we are trying to do negative or positive association. So then Dr. Dey showed you the Schrodinger cat, quantum computing. we are using some of the quantum machine learning in proteomics, especially in myeloma. So there is this model called QProteoML, which can actually predict using support version machine, but all these are, mind you, they have a Q in front because these are quantum trained. So outperforms classical machine learning in predicting drug resistance because myeloma is still an incurable disease, right? So we are trying to predict as early as possible, and also when you are looking at MGUS or low risk smoldering myeloma, we are using this model. Now here is a provocative question. The answer can only be yes or no. Those who feel yes, raise your hands, including Dr. Dev. Can you diagnose acute leukemia without using a microscope? Those who are saying yes, raise your hands. Okay, still it is less than 10%. Okay. Now, let me show you an already old publication, right? Evaluation of a machine learning model based on laboratory parameters for the prediction of acute leukemia subtypes. I don't know whether you can read it, but I'll tell you it has fibrinogen, age, mean corpuscular volume. That means you need a basic automated cell counter and a basic biochemical analyzer, provided you are running the controls and you are calibrating it. This detects even acute promyelocytic leukemia without a microscope in more than 98% cases. And mind you, this is open source. This has been developed in France. It is accessible technology. It can rapidly triage in a district hospital, and it leads to resource optimization so that that person does not have to rush and then you find, oh no, this was not leukemia. So, but obviously the data generators have to be well calibrated. If you write to them, this is already available, and as I told you, APL has 99.7%, ALL has 99.5%, AML has 98.8%. So I consider this as a game changer, and then I want to tell you is, if you are looking at really taking AI in hematopathology to people who need it more, you need to develop such models. Okay? Then multimodal transformers, I think it was already discussed, but there is Maria, which is multimodal artificial intelligence for hematologic assessment. They have some very good names. But if you are the head of the department, or if you are in the purchase committee as Dr. Dev was and then he was removed, you have to understand first what you are using, has it been validated in your population? The companies will always overpromise. Why? Because they need to generate revenue for their shareholders. It's very clear. Google or OpenAI or Anthropic or Perplexity, they need money, right? He talked about federated learning. Does anyone remember? What is federated learning? So here we were talking that if I have Safdarjung's data, then that will be for Safdarjung. What will happen, say, for AIIMS Patna? So just imagine, how many of you use Google Maps? This is more than 50%. Good. So what happens in Google Map? When you see a road is red, congested, do you know who has supplied the data? No. So federated learning is something similar to it, where you give the weightage, the data, but your data remains with you. Because if you just anonymize them, there are tools which can de-anonymize them also. So I have also seen that I told ChatGPT, you forget my name, and then I asked it, what did I ask you to forget? It said, you asked me to forget your name. Then I asked it, what is my name? It told me what my name is. So they never forget, right? Remember this. And then calibration of the model. This cannot be done by the techies alone. You have to continuously give them feedback. Explainability is so important, no black box. Regulatory compliance we have talked of. But this should not be that, when computer came to my school in 1987, it was placed in a room far from the classrooms, fully air conditioned, you have to open your shoes and enter, right? If you keep AI like that, it will never be used. It has to be integrated into your workflow, and you should see that you don't waste more time. You use it and then you leave the OPD 2 hours later. That will not work. But human in the loop, human AI co-validation is so important. So we have discussed the challenges and limitations. Can anyone tell me? I'll see how your human model is working. What are the challenges? Dr. Dey spent more than 5 minutes on this. Come on, say something. Cost, okay. First is data set bias. And this has been proven in Stanford also, between black and white, when Google did it, and this was published as early as 2005. So data sets are always biased in a tertiary care towards the diseased person and towards males, right? So the vulnerable population always is not represented. And then you have huge gaps in generalizability, right? Academic medical centers may fail when deployed in a community hospital. And then black box we have discussed, cyber security and privacy we have discussed, over-reliance risk. Does anyone know what are the new neurological diseases we are developing by using Gemini and ChatGPT? Any one disease?
Insomnia.
Insomnia was already there. These are new diseases with new ICD codes.
And attention deficiency.
This also was there, yeah. So you're partly correct. It is called ICCA, AI-induced cognitive atrophy. It's a disease, and neurologists are now thinking how to treat it, right? Let them think. So over-reliance risk, and then medico-legal uncertainty. So now you have what we call, recently released during the AI Impact Summit, BODH and SAHAI and all that. As acronyms, they are very good. Even DPDP Act is very good, but if you see that if some data leaks from you, the institution might have to pay 500 crores, okay? But in India, there is no dearth of acts. Still, you have violence against healthcare workers. So remember that also. So we are trying to transform every layer. The speed revolution is already there. And we have reached somewhere around 97% diagnostic accuracy, MRD sensitivity, 4 to 8 weeks early relapse. You can detect a leukemic stem cell with 99% accuracy, because that is from where the relapse starts. And obviously you integrate clinical narratives, laboratory time series, digital pathology, flow cytometry, genomics, now possibly exposomics, imaging, and that holistic is always going to act better. The more data you give, the better prediction it is. So you can use it for peripheral hospital triage, right? Where you don't have even good technicians, let alone good well-trained pathologists. It can increase the efficiency of a reference laboratory, because all this quality assessment and all now have inbuilt algorithms, and they can detect what is going wrong, because if you look at Six Sigma and all, they take a lot of time, right? This is where it is already being used. Molecular laboratory interpretation I'll talk, clinical decision support most of you already said, and longitudinal monitoring. So if you know a patient's journey, patient gets admitted in Safdarjung, can you predict what will happen to this patient? We are trying to democratize expertise by breaking geographic barriers, reducing delays. And I talked about cellular vision. I do not have any stocks in it. It is highly expensive, right? But it has a proven accuracy and clinical impact. You have Scorpio X100. I thought I saw it there. They were trying to show it for MDS diagnosis. And then you have something which can read the slides, which is another Indian startup, Sigtuple, and you have AI 100. It also has a urine analyzer, and these are some of the differences. But if sitting here, you think that all will be developed by startups and tech companies, it's not the truth. You yourself can develop something, and this is what I developed in spite of not being a pathologist, along with Indian Statistical Institute. So this is there in XRIF. We said it is an explainable learning system and it can detect blasts just how a pathologist does it, depending on the size, the nuclear cytoplasmic ratio, the granularity. And it's open source. If anyone wants to use it, you just have to write to the PI. I'll give you the details. Even one of my thalassemia patient, right, post-splenectomy, every time reputed labs would tell him that he has leukocytosis and red flags, they would not release the reports. So he is doing his PhD now in digital health. First he did his masters from IIT Bombay, now he's in Quetta Center for Digital Health. He has taken some existing models, classifier enhanced deep learning model for erythroblast differentiation with limited data. It's just that you have to have your own data, which I think you have, and then you go ahead. You can also use generative AI for decision support, but remember ChatGPT and Claude were not developed for this. So, real world clinical queries, unfortunately it seems 7% of the Indians are loading their personal medical data to ChatGPT. There is a huge privacy issue here, right? There are critical limitations to this. The bottom line is, it serves as an excellent clinical adjunct. So how I use it is, when people come to me with Mahabharat, I tell it to generate a SOAP note. I take my own decision and then ask what it feels. If it agrees, it's fine. If it doesn't agree, then I ask certain questions, I rethink and then use it. So I was talking of, H and E giving you molecular insight. So this is a meta-analysis. This was published in December 2025. Not a meta-analysis exactly because it did not have that kind of power. It's a systematic review. Sorry. And this is how it has tried to do it. The most important challenge is still navigating bias and the black box. But Madam was saying that should we call them biotechnology pathologists? What is a better term for pathologists now? The diagnostic integrator. You are the Zubin Mehta. You use different models, but you conduct the orchestra, right? So I'll spend around 5 to 8 minutes on genomic data. Tsunami, I've already told you. eMedicine, private AI have been developed by Illumina. Again, I'm telling you, the device manufacturers are developing it, but AlphaFold is from Google DeepMind. It converges. So how does AI-driven genomic interpretation and validation work? It is something like sitting in the middle, right? It's the nerve center. It gets data from different places and then we are using it. You can develop a IPSNP framework using Python or Django. Basically, we are using it as we use it in a democracy. Some are saying this is pathogenic, some are saying it's not. And right now, the American guidelines say that if 50% say it's pathogenic, you can trust it. So you can use certain protocols to automate the data grind, but consensus is most important as I told you. So performance now is through aggregation. Again, collaboration. If you don't collaborate, you will not be able to improve the tool. I will not go into black box, but there is something called CAPS, right? Context adjusted proportion of singletons. Because you are looking at rare diseases, rare mutations, single cell, and you always have to benchmark the predictors. So don't buy anything which has not been benchmarked. There's a calibration trap also. I'm not going into those details. You have filter chains. You have to cut through the noise. So there is Clinver, which can do meta benchmarking. And then you have an united framework where you automate it, you develop a consensus, then you calibrate it, go back so that iteration and reiteration occurs. So what is the future of genomic analysis? I don't think this is the future. This is in present. It's computational consensus plus evolutionary rigor leading to actionable insight. So all the geneticists can think of themselves as a librarian. right? 3 billion letters per base pair, so actually it is 6 billion per genome. Finding a single typo in a skyscraper of books is very difficult, right? So you have the AI librarian. What does it do? It has a proofreader, it calls the variant and prioritizes, it has a translator, it has an archaeologist, and there are different tools. It's not necessary that you always have to have, several billion parameter models. They are not cost effective and you can't reach the last mile. You can have small models. There are promoter AI, splice AI, deep star, because 98% of the DNA is non-coding. So they actually try to dig it up. What is its evolutionary context? Then you become the sculptor and then you become the linguist using these models. But that also, we wear so many hats. Another hat is the curator, who curates ultimately and then integrates it into PathChat or radiogenomics or whatever, from genomics, transcriptomics, proteomics, radiology. So diagnosing the undiagnosed. But most important is you, right? Librarian is an assistant, but librarian does not write any books, right? You are the author. So from reading to writing, generative biology is helping. I already talked of this kind of roles your AI tool is now doing as proofreader, translator, archaeologist. I will not repeat it. Digital twin is what was described by Dr. Dey, but you all are using digital twins of India's roads. Can you tell me what is the digital twin of Indian roads? It's your Google map. Entire area of Delhi, it is there. Right? You can see where the buildings are, where the cars are. I am trying to make it simple. Nishant talked about clinical intelligence. I will take 3 minutes to talk about medical superintelligence. Okay? Because now we are trying to integrate, these slides are developed by a person. So that is why doctors feel that they cannot do anything. This person is Dr. Shubhankar Datta. He did his MBBS from JIPMER, MD radiodiagnosis from AIIMS. And now he has developed this Datta Crash Lab. So Center for Reliable and Authentic AI Work. These slides are from him only. You integrate multimodal and multi-omic clinical data. You reason longitudinally across time. This is also beyond human capability. So I am trying to show you something which humans alone cannot do it. Predict outcomes, not just detect disease, and operate semi-autonomously within real clinical workflows. Again, I told you, don't keep it in a separate room, with curtains and all that. And remember, medical superintelligence will not come from a single model. Whatever Elon Musk says or Altman says, it will be multiple models, orchestrated, embedded into care pathways. By whom? By us, right? So last 5 years, I'll tell you about certain how much time is left? Overtime? Okay, I'll finish it. So multimodal is text image signal, autonomous workflow I've already talked. MedGemini came in 2024. MedGemma is available and National Health Authority of India has signed an MOU with Google to use it. So imagine if all the PMJ and Ayushman Bharat data goes in, what they will do. We have already seen foundation models for generalist medical. We are trying to develop it, but this is all theoretical, right? But you have now tools where you can be a beta tester. Longitudinal EHR models are Delphi, 2M, Foresight and others. AI can predict when we may die. So, they are becoming more like astrologers. They can get data from ambient scribes. A lot of them are being launched this year, and real world pilot evidence to agentic frameworks. So you will have agents doing everything for you, but if you are not alert, then you are watching WhatsApp while the agent is doing work, you are gone. So GigaPath is there for ECG, you have ECG-M, ECG-FM. It can also detect what is happening during sleep, Milton, Delphi. But most important, And that is where you can play a role is, so what Shubhanka's team has done is, they have validated all the models. I hope you can see it. Some are from ChatGPT 3.5, 4. Still, they are inferior to radiology residents in training, definitely inferior to board certified radiologists, because he's a radiologist, he is doing that. You can do similar in pathology also, but the human has to be in the loop. You regulate, you tackle the ethical challenges, generate synthetic data but never overfit. Global access should be there, and this is how it's a unified diagnostic continuum. Last 2 minutes is, if you have to transform your lab today, how will you do it? So, first is, you lay the physical and organization groundwork for computational pathology. That is what Dr. Dey has been trying. So you go from the glass slide to the cloud, robust digital infrastructure, then strict standardization of data quality and image acquisition. For that, even your stain quality should be good, the staining should be good, and then you integrate interdisciplinary team to dismantle the operational data silos, also looking at the ethical, construct the algorithm engine that drives these insights, and then evaluate the trade-off. If you are seeing by trying to increase the sensitivity, hallucination is more, accept something low, because otherwise you will be signing the report, right? Curation of representative data sets, bring the validated AI technology directly to the patient bedside as a pilot, and then combine rigorous clinical validation in your own setup before saying, oh, I've got the magician, right? Establish strict human in the loop protocols, future proof, because all these models tend to drift over time. It may be working today, after 2 years, it will be a failure. The data scientists can tell you more about that. So it needs continuous monitoring, strict governance, and obviously we have to accept change, right? So change management. My only sincere request to all of you is, don't leave it to others. Okay? You are the referee. If you give it to others, many of our colleagues have become slaves in corporate hospitals. Now, these tech companies will add to the corporate hospitals and you become slaves to both. Because they will say, no, this gives me more EBITDA, more return on investment. So please don't fall in this trap. If you want to read more about it, we have published a book on behalf of Doctors AI, Clinical Updates and Physician Perspectives, where I have written the chapter on hematology. And in Delhi only we'll have this Doctors AI Global Summit. So this is entirely by the doctors for the doctors. Okay? This will be in September. I think you can submit your abstracts. No work is small, right? Try to do something, and you can also become a life member of our Indian College of Artificial Intelligence in Medicine. Keep on enjoying, but be very careful. Thank you.
Thank you, Dr. Prantar. Dr. Prantar?
Yes.
Thank you so much. I have one query.
Right.
Like, we are talking about AI and in the present context, and we are like the Zubin Mehta or the people,
Yes,
that's what your take-home message is. Now my question is that, like, we have become Zubin Mehtas after intense training and learning for last 10 years, 20 years, 30 years and so on.
Right.
So that's how we have progressed.
Right.
What about our residents and the next generation?
See.
Because that kind of work AI is doing for us and we are the orchestra.
Right.
So what about their training? What is the future then for
when
them?
you think in the orchestra, the violinist is less important than the pianist. They have to develop their individual skills. Because if they have to develop that model, train that model, they have to learn. There's no shortcut. If I do not understand morphology and I blindly say, okay, now madam is there, Zubin Mehta, and I will just sit.
So commercially, the Zubin Mehta model is very viable. But in the long run, what is going to happen is that AI is going to be so smart that it's almost going to be Zubin Mehta after 30 years, 40 years?
It depends on how smart you are. I'll give you an example. This basic models are scoring so high in NEET PG and USMLE, right? So 80%, 89%. What does that prove? That the paper setters are not smart. Why did it fail miserably in the UPSC exams? The paper setters are smarter there. So if AI becomes smart, you have to be smarter. If your students are smart, you have to be smarter. And there is no shortcut. So you just shade away all that insecurity. You have to have your domain knowledge to become either the Zubin Mehta or Ravi Shankar or Yedu Menuhin or anyone.
But with my concern is that with time the inputs which we have for becoming smart is going to reduce, because that kind of lot of that job of doing that work is going to be taken over by AI.
Routine work, madam, so you can give more
So,
time to complex things.
see, Dr. Pranthar, even the routine work is an input. After that routine screening, we can decide, okay, this is good and this is bad.
Right.
If we just see the difficult cases, that basic data which a human mind is...
About you. The students should go through the same thing. But now, if you do not have even good teachers, they will learn morphology using an AI. Yes. But they have to learn it. Right?
That's all right.
Yeah,
That's,
I think Dr. K.
You were telling about radiology. There are a very large prestigious journal.
Right.
I think Lancet Oncology or Nature.
Right.
They have done the many thousands of mammogram.
Right.
And they have seen that AI, when said that there is a chance of malignancy,
It is not
that no, they said that it is not true.
Yes, that is what
But it is not.
Yes.
That is the question. Afterwards, it was proved that AI was right.
Yes.
In many cases, they have seen that AI is right.
Yes.
And the thing is that reliability, what you are saying,
Yeah.
the days will come that residents are using their digital tool and AI. And once you use the digital tool, you will be dependent on the digital tool. And then say that, yes, it is, sir, it is malignant or benign. And I know my friend
So there is a dilemma, sir, I'll tell you.
who is doing the routine reporting by taxi when he is going to the lab.
Okay, sorry.
Joyram, Dr. Joyram, he
Yeah.
said that you may heard that Joyram is very famous in South. He is doing that in Joyram. He said that he is reporting with AI and dispatching the fibroadenoma and other cases, very easy cases. And it may happen that one day that digital pathology will be incorporated into the AI system, and then the pathologist will be different attitude. What he said that resident populations particularly.
What Pranthar said was AI cognitive atrophy is a new disease.
Yes.
Something like that we are eventually going to be less smarter because we become smart.
Yes.
when we
No, but what is the definition of smartness?
Talk about one thing actually. Sorry.
Yeah, please, Vishal.
It is not only the dilemma of medical sciences or hematology or anything actually.
Yeah.
Everywhere it is the same. Can you tell me upfront what is 18/7? Now it is not, because you have the calculator.
Right.
You don't require it. So the AI is doing the foundation where you don't require that kind of work. That is already done. That is the repetitive work. Why you want to do that? So that is how the evolution of technology happens, and that is what happens in our world actually. So this debate happens across. So when you ask your son now, why did you do your homework with OpenAI? He said, like, why do I need to do this homework on my own? So the point is the learning has already happened, and based upon that, those models are already there. So they are there to help you out.
But danger is there. You know that
Yeah,
in
yeah.
1988-85,
I think 50 years down the line, till that time, I feel it's correct. But after...
I think,
See, by
No, no,
50
no.
years, you'll have 3 or 4 COVIDs only.
Yeah.
So don't think so long.
I think the chairperson is right, but insecurity is not the answer,
Yeah,
right?
insecurity is
So
not the
we are
answer.
going to be
You have
smarter.
to surf the waves.
We have to be
The
smart.
waves will
Yeah.
come.
I'll tell you something.
Right.
In the process of evolution, disuse atrophy is always there.
Yes.
Always been there. So something else will
I'll tell you.
Don't worry.
I'll tell you something very important as part of the armed forces. Now we've got tumor boards.
Right.
We've got a national tumor board. We've got a WhatsApp group, and we take opinion from the peers who have retired. And everyone is using natural intelligence with ChatGPT, and we are giving concrete tumor board recommendations to our patients who are adopting the tumor board recommendation based on what we are feeding with our experience. And the ChatGPT is structuring that same thing into clear-cut guidelines. For example, my colleague's husband, who's got a neuroendocrine carcinoma of the duodenum, wanted a immunotherapy versus palliative radiotherapy.
Right.
And and the piles of case sheets. We organized that entire thing, and just 2 paragraphs, the tumor board answer was, give him immunotherapy. It was very clear, and they justified it.
Yes.
And we have recommended it, and the patient is doing so well. So question is, how well you use your AI with your smartness.
Yeah. So that
You
is what
have
I'm
to be
saying.
smart.
You have to be smart.
You think that you have to be smart.
So this.
No.
But time is changing.
Right?
That it maybe that you are wrong.
Yeah.
The fight will go on.
Yes, so that topic, that
So you give that example, na? That it intentionally lied. It intentionally lied. So Harari always gives that example.
so
Yeah, makes sense.
so this topic is very interesting. So we can discuss at tea time.
Okay, thank you. Thank you.
Thank you, sir, for that exceptionally insightful session and for clearly outlining the role of AI in modern hematopathology. I now request our esteemed chairpersons to kindly felicitate the speaker. May I request Dr. Rajni to kindly felicitate Dr. Mrinalini? May I now request Dr. Neha Madan to kindly honor Dr. Sufyan Zahir with the token of appreciation. Let us conclude the day on a strong note as we begin our final session. To preside over this session, it is my privilege to invite Dr. Rajni to kindly take the chair. Ma'am is a director professor at VMMC and Safdarjung Hospital. She is a renowned educator and her area of interest is bone and soft tissue pathology. I also invite Dr. Amit Kumar Yadav sir to kindly take the chair. Sir is a director professor of pathology at VMMC and Safdarjung Hospital. His areas of interest include dermatopathology and he has authored around 90 publications along with several book chapters. I now request the chairpersons to kindly introduce the speaker for this session, Dr. Manish Kumar. Sir will be highlighting the most challenging part of AI in medicine, the legal implications. Over to the chairpersons.
It is my pleasure and a privilege to invite Dr. Manish to start with his talk.
Good afternoon one and all. I think you should have given more time to Dr. Chakrabarti. घंटी बजा के जल्दी निकाल दिया उनको आप लोगों ने. You should have. And secondly, I'll be not talking about AI at all, because I'll be talking about consent, not AI. You can implement that consent on AI later on, whatever you feel comfortable. I think as per your schedule, my time is already over. You can you can ring the bell. Because I was listening to Dr. Chatterjee and ma'am ki 10 minutes mein khatam karte hain fatafat. So I'll just finish up within 5-10 minutes. I'll not linger on much. I'll be talking about this consent, which is truly informed or not, which is the biggest problem which we are facing in the hospitals. So since morning, very energetic and enthusiastic presentations I have seen, Dr. Sinha, Dr. Day, and I was watching in my room, sitting on the laptop and listening to it. And now mine is a cooling off period for you all, because I'll be just talking about small things which will be of help to all of you, because sometimes we are doctors, at times we might become patient also. We should know all these things which are very important. My first 4-5 slides are just like UG size slides, so I will not be talking much about them. I'll straight away go to the questions which will be of relevant to us. So, is consent truly informed is my topic today, and the medical, legal and ethical implications of consent practices in Indian hospitals. What is I am looking for. So, introduction of consent, I think all of you are aware of this thing. It is fundamental ethical and legal requirement in modern healthcare. Then I will not discuss about the importance of informed consent. Also, I am skipping, because you all are mature enough and experienced enough that you know what is the importance of informed consent. Type of consent also I am skipping off. Process of informed consent, those who are clinicians know better than us, but then we also are aware of this thing, that you have to tell the benefits and risk of this to the patients, and you have to tell about the alternative treatments available, and if the treatment fails, what all things they can do, and that consent should always be a voluntary consent. The key elements are disclosure of information, that is very important. Patient's comprehension is very important, that he should be able to understand what we are telling to him. It's not like that we have told him something and he is not able to understand, then he signs the report. Voluntariness is very important, that he should voluntarily sign that thing. He should not be influenced by anyone else to sign that record. Competency of the patient is important, like he should not be mentally challenged, or he should not be minor to where he is signing the report, and express or written verbal consent should be there. And ethical principle consents are: autonomy has to be taken care of, that is patient's right to self-determination; beneficence, that is doing good for the patients; non-maleficence is avoiding harm; justice is fairness and equity, which has to be taken care of. Now my major question is major fallacies of consent taking in Indian hospitals. How do we take consent? Anyone? How do we take consent? We just take sign from the person who comes to us. So first thing is this: signature is equal to consent for us and Indian practice as such. So consent is a process of communication and not just a signed form. But what we are practicing is we'll just ask him to sign. Consent is over from our side. So what actually happens? Form is handed over to the patient or at the time of admission, and then patient signs without reading it. So that becomes an invalid consent when it goes to the court of law. Now this is inadequate explanation, because no explanation has been given to the patient. Diagnosis has not been told to him, or proper diagnosis has not been told to him. Alternate treatments has not been provided him. Risk has not been informed him, and then the consequence of refusal of the treatment is also not been informed to him. Problem with this type of consent taking is legally we are very weak, and ethically it is invalid. Consent we take in research activities also. So at times you can correlate that what all things you are supposed to inform to the patient. That is also an important thing, because once you are doing tests and then you are revealing the information. Language barrier is another important thing. Consent forms are usually in English, or nowadays we are having bilingual languages. But then some regional languages there, patient speaks Hindi or he speaks regional language, and then we say no translation, only yahan sign kar dijiye aap. He will sign it. What is the impact? Patient's autonomy is fictitious, not real. Understanding is not there, and consent validity is questionable. So when he goes to court, the defense lawyer easily proves that he doesn't understand this language where he has signed. We are not aware. हमको नहीं पता होता. We are not aware that when we have made him sign the consent form, but we actually don't know that he understands that language or not, what has been mentioned in the form which we have provided to him. Family control consent instead of patient's autonomy. This is again an important aspect. Doctor explains to relatives instead of patient. He will explain to his relatives, this is the problem, this is what the grave situation is, this thing. Patients, though he is mentally competent, is not addressed, and family makes the decision. Later on again, they goes to the court. So ethical issue is violated principles of respect for autonomy, and adult competent patient must be the decision maker, not the relatives. Blanket consent at the admission. This is again one more problem. One-time consent for investigations, procedures, surgeries, anesthesia, blood transfusions. Legal ploys, consent must be procedure specific. For every procedure, you have to take a consent. It should not be a blanket consent. Risk minimizing fallacy. Doctor often says, simple procedure hai, routine hai, tension mat lo, ho jayega. But he did not discuss serious complications, even if it is rare. Failure rates, alternatives, these all things has to be told to the patient that these all things also exist. So he will just say, simple hai, ho jayega, ho jayega. This is again a fallacy. He is just befooling that patient for the sake of his practice. No real dimensions of alternatives. Patient rarely told. Conservative managements, what are conservative managements are available? Only if I am a surgeon, I will be bothered about my thing, how should I go for surgery? Non-surgical options I will not tell. Referral options I will not tell. Options to refuse will also not be told to them. Consent without alternatives is incomplete consent. Consent under stress, there is a section in BNS, Bharati Nyaya Sanhita, section 28, which categorically codes these all three lines. Consent known to be given under fear or misconception is not a consent. If someone is giving you a consent under fear or under some pressure, it is not a consent. So you can never say, I have consent kiya tha, I have taken the consent and I have let me scot free. So consent taken when patient is in pain, in emergency ward chaos, just before shifting to OT, patient not in position for rational decision making, in those situations, it is not valid. If a person suffers from mental illness, intoxicated, is unable to understand the nature and consequence of that to which he gives his consent, again it is not valid, that is an invalid consent. Delegation to junior staff, बहुत सी बार बोलते हैं, just you go and take it, JR, SR, your junior staff or your nursing staff. Again, it is not valid consent. Interns and nurses often take consent. Problem is the treating doctor performing the procedure is responsible for explanation. He is not there just to collect the form signed by someone else and get it signed by someone else. This is his responsibility, not one else's motive. Therapeutic privilege misuse. So doctors often withhold information saying, बताएंगे तो patient बेचारा डर जाएगा. It is not your this thing. Let him take his call. Let the relatives take his call. Whatever. You have to inform him. You cannot misuse his therapeutic privilege. You are just misusing that thing. You should not misuse it. Consent at legal shield, not ethical process. So the purpose shifts from helping patient decide to protecting hospital from litigations. Now what we are doing, we are not giving him autonomy. We are not giving him the full right to have his consent. We are more bothered about protecting the hospital and the litigations and ourselves. So what has happened ultimately, ethics are lost and paperwork culture has been increased. Illusion of voluntariness. This is what a patient will suffers. Patient feels that they cannot refuse because doctor is the authority. Doctor is sitting over there and he is telling sign it. He cannot refuse. If he will refuse, there will be a problem with his treatment part. Hospital is dependency. That is, he is dependent on that hospital. If he will be discharged from here, where will he go and what kind of treatment he will get, and then there will be a financial burden on this thing. Financial pressure will start. Consent becomes submission, not choice. So he will not give consent because of choice, but he will give consent because of submission. So I will give you two case studies, small case studies. Nizam Institute of Medical Sciences versus Prashanta S. Dhanak, 2009. Issue was patient suffered paralysis after surgery due to negligence. Court observation was doctor must provide adequate information about risk and complications before treatment. This was the observations. Then there is another very classical case which has become the benchmark for the Indian medical services also. Samaira Kohli versus Prabha Manchanda, 2008. The issue raised was patient consented only for the diagnostic laparoscopy, but doctor performed hysterectomy with oophorectomy without explaining explicit consent. Court observation was performing a procedure beyond the consent obtained violates patient's autonomy, and the key principle was consent must be specific, informed and procedure specific. Then the summary and the conclusion is, in many Indian hospitals, consent has become a clerical ritual instead of an ethical communication process, turning patient autonomy into a legal formality. Informed consent is not merely a signed form, but a process of communication, understanding and voluntary choice. So I have few recommendations. For health professionals, use simple language, avoid medical jargons, explain risk, benefits and alternatives to the patient clearly. For hospitals, use standardized consent protocols, translated forms, ensure adequate time for consent to be given so that they can discuss and they can just write it in. For policy, mandate-structured consent guidelines in Indian hospital should be made, including penalties for the non-compliance in the accreditation. That's all. Thank you. Fast forward. Thanks a lot. Yes, sir. Please, sir.
Hospital comments that in India, I don't think we are taking any consent. If we follow these things, no one, even I have seen in PGI, in Tata, all are null and void consent.
Yes, sir.
But other things, in the AI I am asking, suppose I have given consent for my operation and all the information, who owns the data? Because my data is used by the company, earning money, the doctors writing paper, getting credit, and what am I?
Sir, consent is a type
Who
of
am I?
contract between two persons. Consent is
Right.
a type of contract between two persons.
Right.
So whosoever is taking consent from you will keep your data, and it is his responsibility to keep it confidential. He cannot release it. There is a clause of privileged communication which he can release provided the court asks him, or it is in the interest of society. Then he can inform to the concerned authorities that this is privileged communication, I am informing you. Like a driver who is colorblind, and if he is driving a vehicle, or a chef who is having a tuberculosis, and if he is working in your kitchen, so that is there. But then rest all, everything is confidential between two persons, and it has to be kept confidential. To contract, it is a type of contract. He is giving you consent. It is not, AI is not taking consent for anyone.
No, I am not saying AI. I am saying the doctors or pathologists are using my image, my information, my molecular data, what's not.
They cannot use it without your consent.
But if you see
So
that
when we
in India,
when we publish articles, we often write a mail to the person that I am using so and so data on so and so table from your table. If we are not doing it, then it is our fault. Tomorrow he can sue us. If we are using any of this table without his consent, then he can always sue us.
See, when you publish in a paper, at least earlier on, you are not giving any names.
Ma'am, that's fine. Earlier the things were not, ma'am, it were not transparent.
No,
Things
now you are not giving any names.
No identifiers are there. No identifiers are there.
Yeah.
The data is anonymized. Then
I didn't understood. Which anonymized data you are talking about? No, sir is talking about that.
even in this,
So for that you don't take a consent.
If anonymous data is there without any name, then I am not aware actually what can be done, because then it's time.
he said that anonymous data, he said that about that Google, he quoted, anonymous will be de-anonymous. It takes fraction of a second to make all of your anonymous data to de-anonymous and identify that persons.
No,
So it is very common. It is truth. What I am saying, it is truth.
So if it can be anonymously made into identifiable,
Yes.
then we have to take consent, sir. Then you cannot release it.
But do
When
we
do
get
thesis,
the consensus?
when we do the thesis,
Do you get the consensus?
No, you take, like when we do FNSC, we have to take consent.
Right.
Correct?
Right.
After that, for publication, you don't need a consent.
But according to him, publication.
You are not using that name.
when you take
No.
that consent, when you are collecting the data, when you are taking that consent, you give it, you ask him that we will be using it for research purpose and publication. So you already taken a consent from him at that time itself.
But
for research purposes.
most
yes.
of the forms
so
it is
publication
not
a part of
mentioned
the
that
research activity.
public, even during FNSC I am saying.
Yeah, it is mentioned.
But ma'am, for blood and all, we don't take blood.
Most of the data, and another thing is that data, who owns the data? My data, who owns the data?
So owning is like if something between you and me.
It is not personalized to a person, because definitely FNSC is being done by
Then MRD is there, medical record MRD is there, they will hold the data of your hospital. MRD is there at the hospital, they will hold the data.
See, let me clarify your point. Under DPDP or APDM, I own my data, you are the custodian of my data. So if my data has to be shared with another hospital, an OTP will come to me. If I agree, then it will be shared with others. So in India, the rule is very clear that the patient owns the data but the hospital superintendent or the hospital administrator is the custodian of that data. That's it. But obviously see, sometimes in retrospective studies, the ethics committee tells, have you contacted them? So the easy way is, see, in PGI, how are the autopsies done? Whenever a patient is admitted, they are signing that if there is something, autopsy will be done. He said blanket does not work. That is how PGI operates, sir.
Like in Mumbai, there is a coroner's law.
Yeah.
So every patient who dies in the hospital has to undergo a transfer.
That's it.
That's the land of the law.
Yeah, law of the land.
So we cannot do and,
Yeah.
Fine, sir. Thank you. Thank you. Thank you.
Thank you, sir, for concluding the scientific session with such a relevant and practically valuable talk. I now request our esteemed chairpersons, Dr. Rajni and Dr. Amit Kumar Yadav, to kindly felicitate the speaker. ठीक है मैं ट्राई करूंगी याद रखने का May I request Dr. Sufyan sir to kindly felicitate Rajni ma'am. May I now request Dr. Chintamani Pathak to kindly honor Amit sir with the token of thanks. With that, we come to the conclusion of the scientific deliberations for today. Over the course of the CME, we have explored the expanding interface between AI and diagnostic practice, from conceptual foundations to practical applications and legal aspects. Before we conclude today's CME, we would like to express our sincere gratitude to our advisory committee for their invaluable guidance and support in making this academic program a success. I request Dr. Mukul ma'am to kindly felicitate the advisory committee.
And Dr. Mukul, Dr. Tathagat sir and Dr. Manjula.
Dr. Mukul, Dr. Tathagat sir and Dr. Manjula Jain ma'am to kindly felicitate the advisory committee. Starting with Dr. Sunil Ranga sir, Senior Professor and Consultant, ex-HOD, Department of Pathology, VMMC and Safdarjung Hospital. Sir has always been a source of constant guidance and mentorship for us, and his support has truly been inspiring. Next, I invite Dr. Poonam Khamra, Associate Professor and Consultant, to kindly come forward for felicitation. Ma'am has supported us at every step, and we are deeply grateful for her encouragement and assistance whenever it was needed. And finally, I request Dr. Charanjit Aluwalia, professor and consultant, to kindly come forward for felicitation. I think ma'am has left the hall. Thank you. Once again, we extend our heartfelt thanks to our advisory committee for their guidance and support. Any academic program, big or small, is always the result of teamwork. This conference is truly the brainchild of a terrific trio of our young faculty whose energy and dedication made this academic extravaganza possible. I request Dr. Poonam to kindly come forward for the felicitation of Dr. Nimisha, Co-Secretary. Nimisha ma'am oversaw the overall coordination of the CME throughout.
I'll come for the photograph, yeah.
Next, I request Dr. Rajni to kindly felicitate Dr. Neelam, Co-Secretary. Neelam ma'am had ensured every detail of the conference was thoroughly managed. And finally, I request Dr. Chintamani Pathak to come and felicitate Dr. Akansha, Treasurer, who meticulously handled the finances and accounts for the program. May we please have a round of applause for their diligent efforts. Behind every successful academic event is a team that works quietly and tirelessly. Today's CME would not have been possible without the dedication of the residents of the Department of Pathology, our postgraduate and senior residents who have truly been the backbone of this program. We sincerely appreciate their hard work, coordination, and commitment in ensuring the smooth conduct of this event. To acknowledge their efforts, we would like to felicitate them with a small token of appreciation. May I request Dr. Chintamani to kindly come on stage to present a token of thanks to Dr. Vyomika, Dr. Dipush, and Dr. Ram.
Here I would like to say, see, all of you worked really hard. It is each one of you who really worked hard. Time doesn't allow all of you to, call you on stage. So I'll just call some of the ones who were like, I could call them any time of the day or night. So I'll just call a few of you, but all of you are really hardworking. And thank you, all of you. It's not that I'm not calling your name, you're not there and not working. Thank you so much. But it's just that time doesn't allow us to call all of you on stage. Thank you, everybody.
I think they're still busy managing the program. May I request Dr. Nimisha to kindly come forward and present a token of appreciation to Dr. Sonam Thakaran and Dr. Mridul. Ram has come. Dr. Vyomika, Dr. Ram, Dr. Dipush, Dr. Sonam Thakaran, Dr. Mridul, Dr. Prabhat, Dr. Nanesh, Dr. Pratiksha, and Dr. Krishan Priya. Let us give them a big round of applause for their dedication and hard work. We would greatly appreciate if our delegates and faculty could take a moment to share their feedback on the board placed just outside the hall. It's on the right side of the door. If you could all please take a moment to share your feedback on the wall. All the delegates and faculty are again requested to take a moment out to share their feedback on the board placed on the wall which has sticky notes on them. With this, we come to the conclusion of the valedictory and closing ceremony. High tea is being served on the ground floor. Thank you all for your participation and wish you a very pleasant evening.